Well, hello everyone. Good evening. Thank you for all of you for joining us this evening. My name is Tim Cole. I'm the Clinical Affairs Manager for Heidelberg Engineering. This is our first clinical webinar of this year, so I'm really excited to introduce our guests this evening. Really start the year with a bang. Some really interesting stuff we're going to see tonight. So just so you know the running order of things, I'm going to just vanish in a moment once I've told you how things are going to work. But in the background, I'm working with my colleague Emily, who's the Marketing and Academy Manager. And Emily and I will be managing all your questions this evening. So with me this evening is Mr. Hani Hasan. Hani is a consultant ophthalmologist from the Northwest Anglia NHS Foundation Trust. And Hani has, for a while now, been doing some groundbreaking work specifically to do with hydroxychloroquine maculopathy. So this evening he's going to be talking about this incredible research he's done with this specific condition. Thank you very much, Hani. Take it away.
All right, good evening everybody, and thank you all very much for joining. Wherever you are in the world, I hope you are staying safe in these difficult times. And I would like to thank Heidelberg for organizing this webinar. This evening, I'll speak to you about hydroxychloroquine maculopathy diagnosis and prediction. In the first part of the presentation, we're going to talk about hydroxychloroquine in general, what's maculopathy and what's the signs and how to detect them. And in the second part of our presentation, I'll speak to you about an artificial intelligence algorithm that we have designed to enable hospitals and healthcare workers to diagnose maculopathy as well as to predict it. Hydroxychloroquine is one of the most commonly used medications in the field of rheumatology, and it is used for management of various rheumatologic conditions. Now, once patients have been started on hydroxychloroquine, they usually stay on it for a long time. And the prolonged treatment is the main risk factor for maculopathy. It causes damage to the macula that is irreversible, and because the photoreceptors will be damaged, this will result in permanent loss of the central visual field. The estimated prevalence of toxicity is thought to be around 7.5% after 5 years and can reach up to 50% after 20 years. So if someone has been started on hydroxychloroquine at a young age, such as 20 or 25, and they stay on it until the age of 45, which is not unusual for patients such as systemic lupus erythematosus, by that age, they will have a 50% chance of permanent loss of vision because of hydroxychloroquine maculopathy. The Royal College of Ophthalmologists have updated their guidelines for screening for maculopathy. This is the most recent version, which was only published about 10 days ago. The annual screening is now recommended only for patients who have been on hydroxychloroquine for 5 years. In the previous guidelines, it was recommended that people will have a baseline screening, and based on that, it will be decided whether they will need more frequent follow-up or 5-year follow-up. The groups at risk, such as patients who take a higher dose, more than 5 milligrams per kilogram per day, kilogram of the body weight, or patients with impaired renal function with a GFR below 60 milliliters per minute per 1.73 square meters of the body surface area, and people who take tamoxifen. These are identified as high-risk groups, and they still require more frequent screening. I will run you through the diagnostic algorithm of the Royal College of Ophthalmologists quickly. Mind you that guidelines for chloroquine are slightly different because we know that chloroquine is more toxic, and the toxic effect can appear on the retina as early as weeks of using the medication. But with hydroxychloroquine, if the patient has no risk factor, the ones we previously mentioned, they can go into 5-year monitoring without any baseline screening. On the other hand, for those who have concomitant risk factors, such as high dose, low kidney function, or using tamoxifen, they will require annual monitoring from the time they start hydroxychloroquine. The recommended tests for screening now are the OCT of the macula and the wide field autofluorescence. Based on those results, patients are categorized either as having normal results or having abnormal results. Visual field testing is being done at the second stage if someone has an abnormal result in the fundus autofluorescence or the OCT. From there, patients who have normal OCT can go back and complete the loop and go into annual monitoring if they've completed 5 years, or more frequent if they have a risk factor. Patients who have an abnormality in the visual field, or in the OCT test and the autofluorescence, they can go back and complete the loop. If that's abnormal, further testing could be considered, such as multifocal ERG. This is usually done rarely because by then we will have confirmation or definite toxicity diagnosis. And that is someone who have got abnormal test results in 2 or more of the screening tests. So by that stage, someone has got abnormal autofluorescence, abnormal OCT, and an abnormal visual field. We will have a definite diagnosis of maculopathy. Such patients need termination of the treatment with hydroxychloroquine, and we need to inform the patient that development of a permanent field defect might not enable them to drive, for example, which is an important medical legal factor, especially in the UK. Also, we need to let the patients know that even after stopping hydroxychloroquine, the maculopathy changes might continue to worsen, and I'm going to explain why is that in a minute. So for us to be able to know what are the signs of maculopathy, I'm going to take you through the appearance of the normal macula. The structure of the retina is a multi-layer of neurological cells, and the retina is thought to be, or the visual pathway is actually one of the, it's obviously the most important sensory pathway of the brain, and it is formed of 3 order neurons, starting with the photoreceptors, which are lying in the bottom part of the retina, in contact with the retinal pigment epithelium. These will relay the information to the retinal bipolar cells, which form the second order neurons, which will then synapse with the retinal nerve fiber cells or the ganglion cells. These will then converge to form the optic nerve and carry the signal to the visual cortex. These are the 3 orders of the 3 order neurons of the visual pathway. The proximity of the photoreceptors to the retinal pigment epithelium is of particular importance in hydroxychloroquine maculopathy, because hydroxychloroquine gets concentrated in the melanin pigment, which is found in the retinal pigment epithelium, until it reaches a toxic stage. And by then, it will start damaging the photoreceptors, because they are neurological cells, they are unable to regenerate, and that's what makes the permanent field defect. This is a normal OCT scan of the macula, and viewing the OCT in the grayscale mode makes it easier to detect any changes as early as possible. It's easy to say that we can look at the retina as alternating layers of bright or hyperreflective and dark or hyporeflective layers of neurological cells. So the top layer is the retinal ganglion cells or the nerve fiber layer. This is an OCT of the left eye because you can see them converging to go over to the right side to enter the optic nerve. In general, the brighter or the hyperreflective layers are the plexiform layers, and the hyporeflective layers are the nuclear layers. So this is the inner plexiform layer, this is the outer plexiform layer, and the most bright one is the retinal pigment epithelium, which has the highest reflectivity. OCT provides an objective and quantifiable method of detecting any changes in the macula. It's the gold standard test when we want to look at changes relating to diabetes, macular degeneration, or retinal vein occlusion, and uveitis. The structural changes in the OCT were found to start in the retinal outer nuclear layer, which is the layer that has the thickest dark band, this layer. Changes in this layer were found to precede or to come before the changes in the photoreceptor damage and the inner segment, outer segment disruption. To obtain an OCT scan with high quality, we use the Spectralis device, and we use the posterior pole scan. This provides us with two advantages. The posterior pole scan relies on the anatomical positioning system, which fixes the fixation points of the OCT on the center of the optic disc, the Brooks membrane, and the center of fixation, which is the fovea centralis. And by that, every time the patient comes for a scan, we will have a consistent scan, and we will make sure that we will account for the rotatory movement of the eyeball. To obtain a posterior pole scan, you need to put the machine into glaucoma mode. From there, select posterior pole. Then the machine will ask you to predefine the center of the optic disc and the center of the fovea. Once that is done, you can proceed to obtaining the OCT scan, which is formed of 64 optical sections. This is the second advantage, that we are getting a highly condensed scan, which allows us later to extract the largest amount of information in regards to the volume of the outer nuclear layer of the macula. To be able to isolate the outer nuclear layer or to look at it separately, you need to right-click on the scan once it's complete and then select segmentation. Choose all layers. Then the machine will start calculating the volume of each of the retinal layers separately. From there, you can go to the thickness map of the OCT, go down to the layer selection panel, and it usually defaults to retina, and it will be showing you the retinal volume as a total and in each of the sectors of the ETDRS circle. These are the numbers in red. You can scroll down and select outer nuclear layer, and this will give you the volume of the outer nuclear layer as a total again, and in each of the sectors of the ETDRS circle, which is a 6 millimeter circle. The central part of the macula, the fovea centralis, is not affected by maculopathy, by hydroxychloroquine maculopathy. It's a foveal sparing disease. So this part will usually keep its normal volume, while the other parts in the circle will start to thin with time. The visual field testing can detect development of what's known as the Ringscotoma. The Ringscotoma develop because the central part of the fovea is preserved, it is not damaged, so the patient will have good central vision. But the parts surrounding it will be damaged, and this will result in a field defect that resembles a ring, and that's why it's called a Ringscotoma. The caveat is that early maculopathy might not be visible as a Ringscotoma. This is actually the end stage. By the time things reach this stage, it's usually game over. The maculopathy is not reversible, and it will continue to deteriorate even after stopping hydroxychloroquine. The new guidelines, the Royal College of Ophthalmologists in England, they don't recommend visual field testing as a first line. And I believe that is a very good step, because visual field is subjective, it requires patient cooperation, and it will miss early maculopathy signs. While OCT is more objective, it doesn't require that much cooperation from the patient, it is much quicker to obtain, and it is easily quantifiable, and it's easier to interpret. Fundus autofluorescence can detect early signs of maculopathy, which are usually fundus hyperautofluorescence. It does that by implementing a light source in the shorter wavelength, 488 nanometers, which will then be absorbed by the lipofuscin pigment within the retinal pigment epithelium, resulting in autofluorescence. In this picture, you can see an end-stage picture of the maculopathy, where the macula has gone into hypofluorescence. So this indicates permanent damage of the retinal pigment epithelium. So far, the fundus autofluorescence is not easily quantifiable. So if a patient is coming annually for screening, and we are doing the autofluorescence every year, it might be challenging to measure the degree of hypofluorescence over the years. It can be done, but it is challenging. It can be done through the quantitative autofluorescence function, which is provided in some of the spectralis devices. To be able to understand maculopathy, we need to understand a bit more about hydroxychloroquine and its distribution in the body. Hydroxychloroquine is very highly water soluble. It is absorbed almost completely from the intestine, and 50% of it travel bound to plasma proteins. It is metabolized in the liver, and it is excreted by the kidneys. The strong binding of hydroxychloroquine to the retinal pigment epithelium, to the melanin pigment in the retinal pigment epithelium, is what carries the significance, the clinical significance of maculopathy, because the retinal pigment epithelium is in direct contact with the photoreceptors. And when hydroxychloroquine gets concentrated in the melanin and reaches a toxic stage, it will then damage the photoreceptors, resulting at the beginning of the maculopathy. For chloroquine is slightly different. The binding is higher and the toxic dose is usually much lower. And that is why we see maculopathy developing much quicker with chloroquine. Chloroquine is not widely used in the UK, but in countries, in tropical countries in general, it's widely used for treatment of malaria, and people can use multiple courses of chloroquine, which can then lead to some retinal damage. Animal models have found that albino eyes do not carry any concentration of chloroquine. This is because of the lack of melanin. Hydroxychloroquine has a very high volume of distribution. In pharmacology terms, the volume of distribution is a theoretical volume. And it is the volume that is required to contain the whole amount of the drug in a concentration similar to that found in the plasma. Using that formula, we find that hydroxychloroquine has a theoretical volume of distribution up to 800 liters. In clinical terms, this means that hydroxychloroquine is very difficult to eliminate from the body. And that is why signs of maculopathy will continue to deteriorate even after stopping hydroxychloroquine, because it is still found in the plasma in the circulation. The poor kidney function is an additional risk factor for developing maculopathy. And again, this is why patients with poor kidney function will have to have more frequent screening, because they are likely to develop maculopathy at an earlier stage, and they are likely to develop a severe form as well. The other significant point is the body size. Most of rheumatology patients are females, and in general, females have a smaller body size compared to male patients. And this smaller body size means a higher volume of distribution in proportion. So that's why smaller females with a low BMI are at a higher risk of developing maculopathy. In the previous guidelines, this group of patients was considered to be at a higher risk. And I still believe they are thought to be at a higher risk, and they should require more frequent screening, because they can develop it earlier and they can develop a severe form. What's the actual size of the maculopathy problem? There has been lots of talks about, is it an actual problem? Is the problem that big? Now, 50 to 70% of patients on hydroxychloroquine have rheumatoid arthritis. As I said, these are all long-standing conditions, and they require the patient to stay on the treatment for years. A survey we did found that some patients were on hydroxychloroquine for more than 22 years as a maximum, and the average was 8 years. So rheumatology patients are likely to start hydroxychloroquine. They like it because it doesn't carry systemic side effects compared to other medications, such as methotrexate, which can cause lung fibrosis and liver fibrosis. The prescribing doctors also like it because it costs less and it is widely available. So it doesn't have to be found in tertiary centers or high-tech centers. It's one of the most widely available medications. One of the important factors that has been highlighted by rheumatology doctors is that the mortality of lupus patients, SLE patients, was found to be higher after stopping hydroxychloroquine. So they want to make sure that the drug is not stopped unless it's absolutely necessary. In this graph, you will see the prescription trend for hydroxychloroquine between 2006 and 2016. In this 10-year period, you will see that the initial average prescription of hydroxychloroquine was about, the total was about 1.5 million doses were dispensed in the UK. By 2016, you can see that the number has gone up to 3.5 million doses. At that point in 2016, if those 3.5 million people taking hydroxychloroquine have continued on it for 5 years, the theory is that by the year 2021, that is after 5 years from that point, we may start seeing a rise in the number of maculopathy patients simply because it takes a long time to develop. And from these numbers, the thought is that we could be facing a storm of patients with hydroxychloroquine maculopathy. Currently in the UK, obviously not all those patients will continue on it for 5 years. And currently in the UK, about 320,000 people are taking hydroxychloroquine for more than 5 years. Based on the college guidelines, all of these patients are eligible for screening. The prescription trend is expected to increase. So to avoid increasing the workload on the health system, we need an objective and a structured way by which we can detect maculopathy and be able to diagnose it at an early stage. How can we recognize maculopathy using an objective and quantifiable method? This is one of the earliest signs of maculopathy. If you look at the picture on the top, you can see that the macula has its normal contour, this double hump, because all the retinal layers have their normal volume. One of the earliest signs is the loss of this layer, which is the outer nuclear layer, this thick, hyporeflective dark band. So when the outer nuclear layer is lost, the macula will collapse and become flat. So this contour is lost. The other point is that the disease is foveal sparing, so this part of the fovea will remain intact. And that's why it will look like a flying saucer, and that's why it was called the flying saucer sign. The flying saucer sign is thought to precede the disruption of the inner outer segment of the photoreceptors and loss of the ellipsoid zone. Ellipsoid zone is the second brightest line from the bottom, or this very thin line. And if you look at the OCT, you can see that this line is somewhat maintained. So the ellipsoid zone looks fine, but the outer nuclear layer is lost. Based on that finding, we use the HiEx, the Heidelberg Eye Explorer software, to track the changes in the outer nuclear layer, like when I showed you at the beginning of the presentation, by segmenting the retinal scan, choosing the outer nuclear layer. We found that patients with normal outer nuclear layer volume will have such a color map. Red in the center means it has a high thickness, yellow and blue in the periphery, which means normally it has a lower thickness. With time, as patients use more hydroxychloroquine, we can start seeing more blue patches appearing in the OCT. And these patches resemble loss of the outer nuclear layer, reduction in the volume or collapse of the retina, of the macula. In the late stage or the end stage, where it reaches the bullseye maculopathy appearance, the outer nuclear layer volume map will look like this, to the graph to your right-hand side. There will be lots of gray areas and blue areas, which indicates collapse of the macula with preservation of the center of the fovea. And this what gives rise to the end-stage maculopathy or the bullseye appearance. In this animation, you will see how outer nuclear layer loss is seen and how does it progress over the years. From here, we were able to take the outer nuclear layer volume as an objective method of detecting maculopathy at an early stage. We used it as a method of tracking the changes, the maculopathy changes, and we used it to predict the probability of developing maculopathy based on the baseline and the normal database. I spoke about autofluorescence at the beginning, and I mentioned that in the early stages there will be hyperautofluorescence. Hyperautofluorescence indicates retinal pigment epithelial stress. If this is not picked up early and the medication was stopped at an early stage, this will then be transformed into the end stage appearance, which is the hypoautofluorescence or the bull's eye appearance. To be able to quantify or to say this is brighter than last time, we could use quantitative autofluorescence. It is available and it can be used as a method of detecting progression in an objective way. So how did we develop our algorithm? The visual field and OCT data were analyzed using multiple machine learning algorithms. So we tried using principal component analysis, independent component analysis, and binary logistic regression. With principal component analysis, it is used generally to compress data. So if you have so many inputs, so many data inputs that you want to analyze, and then you want to transform into a machine learning algorithm so that you can detect changes or predict changes such as maculopathy, the principal component analysis will compress that data for you. So it is not of good use in our case. I can give you an example such as intraocular lens formulae. You have multiple inputs with intraocular lens formulae, and you can use principal component analysis to compress them, and you can then predict what type of an intraocular lens will give you the desired refractive outcome for your patient using principal component analysis. But in our case, it was not very useful, and not all of our data can be orthogonal data, so we couldn't use the PCA. Independent component analysis is used in the medical field by the neurology specialists. They use it to study EEG, the electroencephalograms. To be able to explain independent component analysis, we have this example, which is called the cocktail party theory. So imagine there is a number of people in a party, and these people are all speaking at the same time. And you have got 5 microphones placed in different places in the room. So these 5 microphones are all listening at the same time to this speech, to this generalized speech from different people. Can you then look at a single microphone and say, based on what I hear from this microphone, I can tell who is speaking, and I can tell what are they saying. To be able to do that, you can use independent component analysis. And it was one of the very promising ways of studying maculopathy. So instead of our party people, we have our patients. Instead of microphones, we have our screening tests, OCT, ERG, visual field, color photographs, and autofluorescence. The challenge comes when we want to combine all of this into one algorithm. It is incredibly complex to try and do that with maculopathy. For example, if you want ICA to look at the fundus autofluorescence, it will look at it as a photograph, and it will detect hyper or hypoautofluorescence as a visual change. So to be able to program that, it is such a technical challenge. And that is why we had to look for an easier method and a more affordable method. So the cost of trying to build an algorithm like this needs 6 figures of funding, which might have not been available for us. We looked at binary logistic regression. which is again widely used in the medical field. And I can give you an example with blood pressure. So blood pressure, normal blood pressure or normal value of blood glucose. How did we find out that a normal blood pressure value is between 120 over 80, systolic over 80 diastolic as an average? We did that by looking at a large group of people who are considered to be normal from different age groups. We measured blood pressure for all of those people, and then we can determine cutoff points, which will say anybody who has a blood pressure that is above such a percentage of population will be considered as hypertensive. Anybody will have a blood pressure that is below such percentage of what is normal for the population will be considered as hypotensive. We took that principle and applied it for outer nuclear layer volume. So we scanned about 1,200 eyes of people who have not been on hydroxychloroquine ever before. We gathered the data and we measured the outer nuclear layer volume for all of these patients, all of these normal subjects from different age groups, males and females, different ethnic backgrounds, and so on. The binary logistic regression helps determining the probability of an abnormality or the probability of occurrence of a certain finding based on covariates or based on inputs. So you can have any number of inputs you want. You can analyze them using the logistic regression formula, and then it will give you a binary outcome. You can say that the finding is either present or absent. In other words, it can say the probability of this being abnormal or outside the normal is either below or above 0.05. So we use the visual field and the OCT data as covariates, the retinal threshold in the visual field test, and the outer nuclear layer volume in the OCT. These were our two covariates, and the probability of the dependent variable, which is maculopathy, was a binary outcome, either present or absent based on the p-value. By doing this, we were able to design an algorithm that's cheaper to run and much easier to understand and implement. So this is how it works in a very simple chart. Input from a visual field test from the OCT scan, input from the retinal threshold sensitivity in the visual field, plus or minus quantitative autofluorescence. All of these will be entered into the formula, and then the outcome will either be no maculopathy or maculopathy. This is done based on objective cutoff points, and it is done independent of the experience of the person conducting the test. So by doing this, again, we were able to eliminate the experience factor. The person running this algorithm doesn't have to be medically trained, but they just need to input the data and click analyze, and the algorithm will give you the outcome, either maculopathy is present or absent. Because the database was considerably large, we started taking out inputs and seeing how does the algorithm perform. And we found that the algorithm is capable of detecting maculopathy using outer nuclear layer volume alone without any input from visual field or from quantitative autofluorescence. The algorithm still functions normally. We published our findings in the Eye Journal in the end of last year, and we generally use the Spectralis device because, as far as we know, it's the only one that provides a quantitative measurement of the outer nuclear layer volume. We take the numbers in red. These are the volume per sector of the outer nuclear layer. So this is for a normal subject. You can compare that to someone who has got maculopathy. You can see that they have got collapse of the outer nuclear layer represented by the blue patch in the visual field in the OCT scan, which is in turn reflected by the loss of volume of the outer nuclear layer. All of these numbers are inputted into the algorithm. We take the visual field test. This graph here is what we are after. These are the absolute retinal thresholds. And we use the retinal thresholds and not the mean deviation or the pattern standard deviation, because we have our normal database. So we can compare that to our normative database. All what we need is just the retinal thresholds, which are 68 points. We then omit the central 4 points. This is for someone who doesn't have maculopathy, and this is for someone who has got maculopathy changes. And you can see the difference in the grayscale chart. Which are volume in cubic millimeter for each of the 8 sectors in this circle, the ETDRS circle. And we have got 68 points in the visual field. We omit the central 4 and we omit the central part of the fovea because we know it's a foveal sparing disease. The next step is that we wanted to link the structure, which is the OCT, to the function, which is the retinal threshold. To do that, we taught the algorithm to look at the retinal sectors that are correspondent. So the top part of the macula with the bottom part of the visual field, the nasal part of the macula with the temporal part of the visual field, and so on and so forth. From there, the algorithm will do the calculations in the background. It will be a huge number of yes and no gates. If someone has got abnormal volume in one sector, 2 sectors, abnormality in the visual field alone, abnormality in the OCT alone. So the algorithm will do all of that calculation and then will give us an outcome, whether the patient has maculopathy or the patient has a normal scan. We needed validation for this algorithm. So we took patients who have been tested using our algorithms and we did multifocal electroretinogram testing on them. The ERG is considered as the gold standard for maculopathy diagnosis. It is not flawless, but it is regarded as a gold standard. It is requiring patient cooperation. It is time consuming. It is not widely available. For example, in England, it is found in the tertiary centers or the research eye units. So we sent some of our patients to go and have multifocal ERG testing. We sent 9 patients, 18 eyes, and half of those patients, according to our algorithm, half of the eyes, 9 eyes, showed features of maculopathy. 9 eyes were tested normal using our algorithm. From there, we calculated the confusion matrix, and we were able to calculate the sensitivity and the specificity of the our algorithm. I beg your pardon, the test positive, these are 11 patients who tested positive using our algorithm, and 7 out of the 18 patients tested negative or normal according to our algorithm. The true positive are the patients who tested positive using the ERG. Those were 12 patients, and the true negative were 6 patients, those who had normal ERG. And from there, we were able to calculate the sensitivity and the specificity. Our algorithm has a sensitivity of 83.3%, specificity of 83.3%, positive predictive value of 90%, and a negative predictive value of 71%. Using the multifocal ERG to validate our results gave us an extra layer of safety because multifocal ERG changes can be easily detected if someone has got advanced maculopathy and if you have a good point of reference to compare to. So by doing all that, we had an extra layer of safety, and we were able to design an iOS software. It is based on the algorithm we designed earlier. It's called the Hydroxychloroquine Screening Program, and it is now available on the iOS platforms, iPhones and iPads and Mac. It is not available for the general population because we have this, now it's the third version, which is a trial version only. The idea behind it is that it allows healthcare workers to diagnose maculopathy, to track the changes in maculopathy, and it allows prediction of maculopathy changes based on the patient's inputs, visual field and OCT, but mainly OCT. We will also be launching a web-based version soon, so that if someone doesn't have an iOS device, they can still access the software and use it. The software, the application has two portals or two interfaces. The clinician portal, where a clinician can enter the data, such as OCT outer nuclear layer volume, and can analyze the data. This can be done using OCR, optical character recognition, from an iPhone or an iPad. You can simply take that and take a snapshot of the OCT report. The algorithm will then extract the volume data. It will require entry of the patient's age, gender, and demographic data. And then it will give you a diagnosis based on an objective method. It can also be used to take snapshots of the visual field test. Again, the algorithm will extract the data in the same way and analyze it in the same way. We have the patient portal, and this can be installed by patients, and they will be able to have a read-only version of their screening tests over the years. So they will be able to know their screening tests, they will be able to know the progression in their screening tests over the years, what is the trend, if it's downwards or an upwards trend. They will be able to follow that through the application as well. The interpretation of screening tests using our algorithm is in line with the guidance of the Royal College of Ophthalmologists. The college considers definite maculopathy to be having abnormal test result in 2 of the screening tests. Possible maculopathy is having an abnormal test result in 1 of the screening tests. This is the exact same principle we use in our algorithm. If someone has got abnormal result in an OCT and the visual field, 2 screening tests, they will be considered as having definite maculopathy. If someone has an abnormal test result in 1 of these 2 tests, they will be considered as having possible maculopathy. Patients with possible maculopathy don't have to stop the treatment, but might require more frequent monitoring. Patients with definite maculopathy will have to stop the treatment. So in summary, our algorithm provides a practical solution for the capacity issues, especially in the post-COVID era. That storm of patients we are expecting to encounter can be solved. The problem can be solved using an objective and structured way that does not require a clinician input in all stages. It also eliminates the variation in interpreting test results. So what is considered normal for a clinician who is experienced could be considered abnormal for a clinician with less experience. So to avoid this variation in experience, we used objective cutoff points that are not subjective to experience. Our software allows for the screening service to be run in an automated fashion. The clinics can be done on virtual basis, and the patients can have their OCT or visual field or autofluorescent tests done in places other than the hospital, places near to them, to their houses, such as optometry practices or GP surgeries. From there, the data can be entered by a clinician or a non-clinician person, such as an administrative member of staff. The data can be entered by taking a snapshot of the test results or by exporting data as a photograph and uploading it onto the algorithm, which will then extract the data, do the analysis, give you a result, and give you a report, which can then be viewed by the patient at their end using the patient portal. So this will allow less or more decentralization of the service and less busy clinics, so that the clinics can run and face the backlog we will see after the end of the COVID, hopefully soon. Thank you very much, everybody, for joining, and that's the end of my presentation. I'd like to thank Mr. Guy Smith, who is a consultant surgeon in Swindon, Great Western Hospital. He has been a main partner in the development of this program. I would like to thank the fantastic eye clinic staff in Swindon at the Great Western Hospital and our colleagues here in Northwest Anglia NHS Foundation Trust. I'd like to thank you for your time, and I hope you found this presentation useful.
Thank you very much, Hani.